My name's Miles Prince. I'm a haematologist from Melbourne, Australia, and today I'm going to talk to you about a patient case which I think is very interesting in the context of the availability of the monoclonal antibody bound to the immunotoxin brentuximab vedotin. This is a case of a male 63-year-old patient who was previously very well, a history of hypertension and a history of exposure to hepatitis B. He has hepatitis B antibodies but no active DNA. And he presented with lymphomatoid papulosis with multiple lesions over his limbs and particularly his legs and forearms. And from our point of view, it was a pretty straightforward presentation of classic LYP with no evidence of systemic disease. We treated him as such with 20 milligrams of methotrexate, and we started that treatment in August 2013, and he had rapid resolution of his skin lesions. However, by March of the following year, 2014, he'd had complete resolution, but he developed an inguinal node. So in 2014, we staged him with this inguinal lymphadenopathy. He had a PET scan which demonstrated localized disease just to that inguinal node, and he had no evidence of internal lymphadenopathy. He had no evidence of skin lesions, and that's a really important characteristic because, as you're aware, lymphomatoid papulosis is in the spectrum of CD30 lymphoproliferative disorders, where we have LYP at one end and primary cutaneous anaplastic large cell lymphoma. And overarching that is the possibility of it being associated with other malignancies such as mycosis fungoides, Hodgkin's disease, or other lymphoproliferative disorders, and even systemic anaplastic large cell lymphoma. So we're faced with this gentleman who had a nodal disease, and we really felt that this was a manifestation of a primary cutaneous anaplastic lymphoma involving a lymph gland, or even the possibility of it being an ALK-negative systemic anaplastic large cell lymphoma. And it's fair to say to differentiate between those two can be quite difficult. It was really important to get a node biopsy from this patient because these lymphomas can be either a local manifestation of a primary cutaneous lesion or in fact systemic anaplastic large cell lymphoma. It was ALK negative. That's critical because the cutaneous lymphomas are always ALK negative, but could this have been a systemic manifestation with ALK negativity? There are two molecular tests that can be done to assess that. One is DUSP22 and the other is TP63. Unfortunately, at that stage, we didn't have the availability of those because that could have helped us differentiate between the two. Nonetheless, we managed this patient as potentially having a systemic anaplastic large cell lymphoma, and we elected to offer him chemotherapy. We decided to treat the patient with 3 cycles of CHOEP chemotherapy, that's CHOP plus etoposide, and we did an interim PET scan after 3 cycles. The overall plan was to move ahead and complete 6 cycles of CHOEP treatment. However, the interim PET scan was suspicious for progressive disease. We pushed on, and at the end of 6 cycles, we discovered that in fact this patient definitely had progressive disease on repeat PET scan. Thus, the plan was to move ahead with autologous stem cell transplantation. So what we did is we moved to salvage treatment, as most of us would, with a combination of ICE treatment, that's ifosfamide, carboplatin, and etoposide. So after 6 cycles of CHOEP chemotherapy, we undertook another PET scan, and unfortunately this showed definite evidence of progressive disease. So we elected to move towards high-dose chemotherapy and autologous stem cell transplantation. So we initiated salvage chemotherapy with a gemcitabine-based regimen consisting of gemcitabine, ifosfamide, and vinorelbine. He had 2 cycles of this and tolerated the treatment extremely well, but unfortunately PET scan after that showed progressive disease. So we were left with a gentleman who had anaplastic lymphoma, who'd had CHOEP treatment for 3 cycles, suspicions of progression, confirmed progression after 6, moved to salvage treatment with the plan of autologous transplantation, but after 2 cycles of salvage clearly had progressive disease. So a patient who was chemotherapy refractory. So we weren't happy to proceed to autologous stem cell transplantation. Therefore, what was our choice? So it was critical for us at this stage to confirm that we were dealing with the same disease. So we made sure we re-biopsied the lymph node and it confirmed the same pathology. He also developed a rash, an associated eosinophilia, and we biopsied that rash and it too showed CD30 positive anaplastic large cell lymphoma in both the nodal disease and the skin disease. So given the refractory nature of his condition, the obvious choice was really to move to a novel agent. And in this situation, the obvious choice to us was brentuximab vedotin, a treatment directed towards the CD30 positive cells and with data and good evidence in the context of anaplastic large cell lymphoma of efficacy. So he started the standard regimen of 1.8 milligrams per kilogram delivered every 3 weeks. And he tolerated the treatment extremely well. He commenced the treatment in December 2014 and he had a very rapid resolution of the skin disease and the palpable nodal disease, and he felt well. So after 3 cycles, so 9 weeks of treatment, we repeated the PET scan and this showed a dramatic, complete resolution of the lymphadenopathy. So where are we now? This man has now completed 16 cycles of brentuximab vedotin, tolerating the treatment well, and importantly has had no evidence of peripheral neuropathy. Now in Australia we have the maximum provision of 16 cycles of treatment, and in fact this man's done very well because a lot of patients develop some peripheral neuropathy along the way and require some dose modification, etc. In a world where we may be able to get ongoing treatment, that would be one of the options. But we are in a situation where we have to stop the treatment at this point and make a decision. And there are a number of decisions that we could take. One would be to stop treatment completely and simply observe. The second would be to offer him some form of transplantation, which would be autologous transplantation where you have already stem cells stored. And the third would be consider allogeneic transplantation in this setting. And they are all quite difficult options. And in fact, one could consider perhaps observing and offering any of those options at a later date. So I was really faced with this dilemma. What does the data show and where do we move next? So our quandary really is, should we be offering this man a stem cell transplant and what's the utility? Would he be suitable for an allogeneic transplant? And the relative uncertainty about the durability of this remission that we've achieved. So we tissue typed him and in fact he had no histocompatible siblings, and that made the option a little bit more easier in some ways, in that the potential morbidity associated with an unrelated donor transplant was going to be higher than the morbidity of a sibling donor. And we knew that he would tolerate an autologous stem cell transplant, and yet we were still anxious about perhaps him relapsing within a relatively short period of time, and whether we were going to be able to offer him further brentuximab vedotin at a later stage. So I sought a number of opinions. I spoke to a local team of allograft colleagues, and they were not so keen because of the potential morbidity and that he was in a complete remission, recognising of course that the benefit of an allogeneic transplant may be best in the setting of a minimal residual disease. They were also anxious about the complete refractoriness of his disease to both the CHOEP chemotherapy and his salvage gemcitabine treatment. I then sought an opinion via email, as we do nowadays, to one of my colleagues in New York, and his response was lengthy and, fair to say, really trying to hedge his bets, and he admitted this. I think the thrust of it was that he felt that allogeneic transplantation would be a good option if we felt that the patient was clinically suitable, or perhaps observe for a while and then offer allogeneic transplantation. If we felt, or if the patient felt, that allogeneic transplantation was not an option, he felt that autologous transplantation was a reasonable option. I sought a second opinion from the other side of the Atlantic, from one of my Italian colleagues from northern Italy, and his response was brief, but to the point, which was he felt that autologous transplantation was appropriate. And finally, I sought the opinion of a UK colleague who happened to be presenting in Australia at the time, and his view was autologous transplantation. So what's the data? So the best data we have is from Barbara Pro's publication of brentuximab vedotin in systemic anaplastic large cell lymphoma, and that's an excellent study. But it does show the difficulties of interpreting that data in the current climate of really a limited follow-up. A lot of the patients went on to autologous transplantation or allogeneic transplantation, and some patients were simply observed, but we don't know the situation in which those patients who did not undergo transplantation and the reasons for that. So we have to make a decision. In this particular patient, is there a tail to the curve? Is the patient going to have a durable response? So we've decided that we are going to move ahead with autologous stem cell transplantation. This, we believe, gives him a chance of cure, but we are circumspect to the fact that this is a man who was chemotherapy refractory. But it is important to recognise that in Barbara Pro's paper, there was a large cohort of patients, or a substantial number of patients, who did receive brentuximab vedotin who were chemotherapy refractory. So there were patients in that study that were like our patient. So we've elected to move to autologous transplantation, and what we're going to do is we'll simply observe this patient. If the patient progresses, then we will offer him salvage brentuximab vedotin. Hopefully he'll respond quickly. There is evolving data that BV does achieve responses when used as a further treatment in patients that have previously received it and responded, and then we'll move him on probably to allogeneic transplantation. So in summary, we're left with a patient who has chemotherapy refractory disease, who we've moved on to brentuximab vedotin, who's had an excellent response, achieved a complete remission, and what do we do now? We've elected to move ahead with an autograft, and then if the patient progresses, offer him an allogeneic transplant. Equally, one could observe and then offer transplantation, and I think that is a reasonable option. Could we have done anything differently? Well, I don't think so. I think the big questions in the future are going to be, well, in these patients who have got relapse disease, should we be offering them chemotherapy plus brentuximab vedotin? How quickly should we move to transplantation? What is the potential benefits of allogeneic transplantation or autologous transplantation, or even could we use brentuximab vedotin as maintenance treatment? Now, none of those are available options for a lot of people because of regulatory constrictions, but I think they are important questions, and it really shows what an exciting time we have and a difficult time we have in managing these patients. It's great that we can achieve responses, but we have to aim ultimately in making those more durable. Thanks very much.